doctor, for your report. We have today 7 candidates.
Yes, candidate 1.
Yeah.
Candidate 1, are you ready?
Yes, I am.
Okay. This is 30 years old female patient presented with dyspnea.
I have been presented with.
Request,
I want. Yeah.
request control.
Okay.
Okay.
Okay. I have been presented with a frontal chest radiograph for a 30-year-old female patient with history of dyspnea.
Mhm.
Okay. Yes. I didn't see any obvious abnormality, so I will go through my checklist. I cannot see any lung nodules or masses within both lung fields. There is no pleural effusion. The cardiomediastinal contour appears normal. There is no evidence of consolidation or collapse seen within both lung fields. In checking the bones, I can see that there is no bony abnormality seen within the ribs. Also, the clavicles and the available images of the shoulder joint bones appears normal. Regarding the vertebral spine, I can see that there is sclerosis noted within the vertebral body, which could represent
Don't
projectional.
worry about it.
Yes.
Yeah, don't worry.
Both hemidiaphragms appears normal, and there is no air seen below the diaphragm, and there is no evidence of calcification seen within the upper aspect of the abdomen. I will see the medical records for this patient and correlate with the clinical history of this patient rather than dyspnea. Then I will talk with the referral doctor and suggest to do chest CT scan.
Why?
Because the patient is complaining of shortness of breath. I want to know why this patient is having shortness of breath despite being.
But you must
Yeah.
first rationalize the CT.
Okay. I want to
Why
see if
did
there
you
is.
request a CT?
Yeah, I want to see if there is anything within the hidden area, such as the retrocardiac or abscess of the both lungs. I
Okay,
cannot
go on.
see. I cannot see any mass lesion within the retrocardiac shadow in the left-sided or in the both lung abscesses.
Okay, what else? What else?
I want to check the
What else?
breasts to see if there is any breast lesion or asymmetry within the breast, which I cannot appreciate. Second of all, uh, I cannot see any mediastinal shift or enlargement within the
Okay.
lines of the trachea or esophagoazygous line. All of them
Yes.
appears within normal parameters. And I am
Yes.
checking the soft tissue. I cannot see any abnormality within the soft tissue of this patient.
What else? When the X-ray, chest X-ray looks like normal, the patient has significant complaint, and you revised all review areas. What is your next or your last chance to find something? I
I
think
will ask
I
for
mentioned
lateral.
before in my lecture before many months. Three last chance review areas you must check. Very subtle finding will be within of one of these three.
Actually,
I
I
will
didn't
help you.
remember. Yeah.
I will help
Look.
you. See,
Okay.
this is very, very typical scenario. Our candidate review all the review area. Mhm. Sure, it is normal. So the only chance to do or to search between three things, the soft tissues and compare with comparison. This is the key word. With comparison, you will not tell the examiner I will do like with comparison, but I'm telling about the technique. Compare the soft tissue here, right here, looks like no. Okay, compare the bone here with here. Compare the density and the vascularity of lung here by here. Hmm. Sorry, answer this. 1 second. Sorry. Hello?
Ah, yeah, I'm with you.
Okay.
Okay.
And have a look at the lateral. Have a look at the lateral. This is the last chance for you. Okay.
Okay.
I think we should look here first. Sorry, it was by mistake here. Uh, okay,
Yes.
let's have a
Here I
look
can
here.
see some finding. There is difference
Yeah.
between the vascularity within the right lung in comparison with the left lung. I think there is oligemia seen within the pulmonary vessels on the right side. I think this is called Westermark sign, which is
Yes,
seen in
excellent.
pulmonary
Mm,
embolism.
yes.
But is this the same patient, the same X-ray, or the different X-ray?
Yes, it's the same patient, but I forget to and start with this one. This is the 6 months before the complaint. So sorry, my colleague, it is normal. Our concern about here and the same recommendation. If the chest X-ray looks like normal for you and you finish all review areas, you must do three things. Comparing the soft tissue on both sides, comparing the density of the lung and including vascularity on both sides, looking at the bone and comparing with both sides. Okay, Dr. Ali, go on.
Yeah. So in my
So
routine practice,
what do you
in
think?
this,
Mm.
yeah, I think this is representing Westermark, which is specific for pulmonary embolism. So I will urgently confine my finding to the emergency department and ask for axial chest pulmonary CT angio to rule out any filling defect and for confirmation.
So you considered here oligemia here, okay? What
Yeah.
else? There are
Um,
something very important. Another sign, very important sign.
yes. I want to compare again between the right and left lung.
No, okay, you compared already and you find differential oligemia here. Anyway, I will give you my feedback. This is the CT. What is your concern? Why you want to do one CT for this patient?
Yes, because I want to look for any filling defect within the main pulmonary arteries or within the branches.
Okay,
Here I can
go
see
on.
that there is, yeah, I can see that there is a large filling defect seen involving the right main pulmonary artery and which appears extending into the left main pulmonary artery. This is which is called saddle pulmonary embolism. If it is appears
Where is the
complete
saddle?
continuous,
One second, 1 second.
yeah.
Where is the saddle?
If it is continuous
Where?
with the left side, but in here in this case it is not continuous, so it is not complete saddle. So this is massive pulmonary embolism seen involving the right main pulmonary artery and its branches. In my routine practice, I want to change this into the lung window to see if there is any evidence of which shape lung infarction seen in the periphery. Also, I want to
This
see,
is lung.
yeah,
This is
yeah.
lung.
Here I
Okay.
cannot see any. evidence of infarction. Second, I want to check if there is any right-sided heart strain, which is manifested by shifting of the
Okay, okay. Show me. See, doctor, the case is with you. Okay.
okay.
So when you're telling the examiner, I wanted to check. You should after that tell him, oh doctor, there are no or there is strain. So
Yes, here I can see that there is normal bowing of the interventricular septum to the right side, so there is no ventricular right-sided heart strain. Also,
mhm.
I want to check the upper abdomen image. Uh, there is no reflux of the contrast into the inferior vena
What is
cava.
your next step? What is your next step?
My next step, I will urgently
Yeah.
combine my findings to the referral doctor and start anticoagulant therapy.
What else?
Um,
What
I
else?
want to see if the patient have. I will recommend the Doppler ultrasound for the lower limbs to rule out any
Yeah, it's very
DVTs.
important. Very
Yeah, yeah.
important. Yes. Could intervention and radiology have a role here?
Yes, because if there is any history of DVT, sometimes they can put IVC filter.
Okay. What else?
Um,
Could intervention and radiology have a role in thrombectomy?
yes, they can do retrieval by
Really?
femoral catheter.
Yes, maybe have a role. Okay. Thank you, doctor. Take to home message. Look, compare with this hilum. Could you see any difference? Hello?
Yeah, yeah, yeah. There is a difference between both hilum.
This is very important sign of pulmonary embolism. Either the oligemia or either the differential asymmetry of both hilum. This sign has a specific name. I didn't remember, but at least you pick up and correlate with patient complaint. Second, take care when you are examining CT angio. Number one, don't over diagnose. This is not sudden. Saddle impulse is a disaster. This is not sudden. Saddle must cross to the other side, bridging from here to here. This is not sudden. So this is complete thrombosis and blockage of the right pulmonary, right main, and its segmental branches. Okay, looper and segmental. Number two, what is this? The left side has something here. This one. Okay, maybe almost it is blockage of the lingular artery. See, blockage. Number three, you must tell the doctor the heart didn't show any thrombi, neural thrombocytes, or any myxoma. It's very common. And even the IGC, but here it is very difficult to assess IGC. So I will do lower limb Doppler. Why? Because if you treat this patient without treating the cause, he will rethrombose again. Okay?
Yeah.
Low. Okay.
Yes.
Okay. Next, uh, I think the best plan to assess, there are no obvious straining here, but I think straining also needs sagittal oblique plane to assess this interventricular strain. Okay. Um, thank you so much. It is emergency. We must talk as much as possible um, about interventional radiology. Even here, if you told him interventional radiology may have a role, it will be very, very acceptable because the examiner is radiologist. Thank you so much. Again, when the X-ray looks normal, even in the bone, I mentioned this technique even in the bone. compare both sides of tissue, compare both side density, and compare the bone in each side. Thank you so much. Next candidate.
Yes,
Hello.
hello, doctor. This is me.
I think we lost Dr. Ali.
I'm with you, sir.
Lost Dr. Dr. Ali, can you hear me?
Yeah. Hello?
My colleague, my voice is clear or not?
Yeah, it's clear.
Okay, thank you, Dr. Ali, so much. You did very
Thank
well.
you.
Next candidate, this patient is 50-year-old patient. Doctor, could you request control, please?
Yes, I will.
This patient is
Mm.
50-year-old patient complaining of dyspnea. Go on.
All right. So
Sorry, 1
I'm
second.
going to have, yeah, I'm
1
scrolling
second.
now, I think.
Go on.
Okay.
Yeah, go on.
Yeah. All right. So this is axial cuts in pulmonary window of a CT chest in a 50-year-old female patient presented with shortness of breath. On initial view, I can see that there are extensive interstitial extensive interlobular septal thickening and the subpleural cystic changes in rows, giving the appearance of honeycombing. There is also random cystic lesions, subpleural in nature, and traction bronchiectasis. All findings point towards an underlying pulmonary fibrosis. The predominance is mostly basal. There is craniocaudal gradient with the basal segments more affected than the apical segments. There is also some here. I can see there is a consolidation, dense consolidation. I would like to assess better on soft tissue window. Yeah, so the cystic lesions here are thin-walled and scattered variable sizes. So what I'm thinking now is there is a cystic lung disease on top of an interstitial pulmonary fibrosis with a solid consolidation at the right lower lobe. So these three findings put together, I'd like also to assess the mediastinal window for lymph nodes and pleural thickening if possible. Is that possible? Yeah, all right. So yeah, these are coronal images in mediastinal window. Oh, that's, yeah, right. I can see small volume mediastinal lymph nodes. They look reactionary. Hilar lymph, sorry, I want to assess the hilar lymph nodes. It's not contrast scan, I assume, so. Yeah. I think there are some, I'm not sure if these are hilar lymph nodes or pulmonary vessels. I think these are pulmonary vessels. I can see really bulky mediastinal adenopathy to make me suspicious. As for the right lower loop consolidation, it shows here some air bronchogram, so this could be infective in nature. There's no pleural effusion. No pleural effusion. Of course, there is loss of lung volume bilaterally. The airways are so here, especially at this segment here. Sorry, it's jumping a little bit. Yeah, oops. Yeah, here. I'm not sure if this lesion here encroaches on the airway. I'd like to go back to the axial images to assess, but this is something I will get back to later. So, yeah, in my normal practice, I would also assess the bone window. And yeah, so there is a cystic lung disease on top of usual interstitial pneumonitis with right lower lobe consolidation, likely infective in nature. I'd like to convey my findings to the referring physician and suggest a referral to the respiratory specialist for treatment of pneumonia. Later on, the patient might need a referral to an interstitial lung disease (MDT) for further management and respiratory support if needed. The type of cystic lung disease I'm thinking here, because it's very thin-walled and sporadic, with no predilection and variable in sizes. I'm thinking it could be lamb. However, in lamb, the lung volumes are not affected, and there is usually chylothorax. I can see those here to support the diagnosis, so I would just consider these cystic changes as part of the interstitial pulmonary disease instead, and stick to my initial diagnosis of usual interstitial pneumonitis with a super added right lower lobe infection.
In your opinion, what is the underlying cause? Would you find any clue?
Okay. So I forgot to assess the underlying causes, the associating findings of other collagen vascular diseases, for example, dilated esophagus. Can I go back to the axial images, please?
Go on.
Yeah. Yeah, so the esophagus here appears, the upper esophagus is not dilated. The lower esophagus is a bit dilated and fluid-filled, I believe.
So,
Yeah, so
what else?
it points towards a collagen vascular disease such as systemic sclerosis. I'd like also to assess the medial and lateral aspects of the clavicle for any erosions and the shoulder joints for any arthritis. Yeah, so there's no bony changes as far as this lung window. So primary concern will be about an underlying cause of scleroderma or systemic sclerosis. The patient might need rheumatological referral as well to correlate with serum anti-nuclear antibodies and start disease-modifying treatment. And also, if there is any skeletal radiographs of the patient, I'd like to review them as well to confirm the diagnosis.
See, doctor, you describe very well an interstitial process, but there are two items you included in your description. Cystic scattered, thin wall cystic lesions and lymphadenopathy. Could this indicate something, or could this guide you to the underlying cause?
So when I think of cystic lung disease, I have a very limited differential. It's either Langerhans histiocytosis, which is not typical in this case. These are not
Okay,
bizarre shaped cells, cysts, or thick
but
walled. There are
but
no nodules.
could you
Mhm.
remember the age of the patient?
50.
Yeah, so
Is
it
that?
is very far from
It's very, yeah, exactly. The
Langerhans
age isn't.
cytosis.
Yeah, true. So I only have lymphangioliomyomatosis, as I said before, and the cystic lung disease associated with Birt-Hopf syndrome, which is rare and associated with renal tumors. Yeah, the cystic changes can also be there if the patient's immune status is reduced and there is suspicion of pneumocystis jirovecii pneumonia. In this type of disease, I'd like to,
Okay, but one second. PCB, you are talking about PCB, okay?
yes.
Yeah, but one second. Did this signs or appearance related to PCB?
No, because in BCB, I'd expect to see
So,
very
so,
high
so,
nerve parameters.
listen
Yeah.
to me, please. Listen to me, please. My advice to you, you are
Mhm.
speaking about the case in front of you, either from your expectation, your differential diagnosis, anything related to this case. Okay. So
Yeah.
we talking about this case. Okay. Scatter consider this pneumococele or thin wall cystic lesion plus
Yeah.
lymphadenopathy. Could you ask about any old history of previous diseases in this patient?
I mean, if we're talking about lymphadenopathy, I would like to ask about previous sarcoidosis, which is the
No.
most common disease for
Sarcoidosis, see,
cysts.
doctor, see. Sarcoidosis will be more upper than lower,
Epic.
and you will see more calcified lymph nodes. Okay?
Mm-hmm.
Which disease, frankly,
Mm-hmm.
which disease is associated with multiple scattered thin wall cystic changes? This is not sure emphysematous changes. This is thin wall nematocell considered. And
Mm-hmm.
on top of interstitial lung disease. What is the name of this disease? Plus very obvious lymphadenopathy. See,
Mm-hmm.
there are lymphadenopathy. There are mediastinal and I think axillary. No, axillary. So
Mm-hmm.
what come in your mind?
Um,
First, we exclude usual interstitial pneumonia or non-specific interstitial pneumonia. The
mm-hmm.
commonest three and organizing interstitial pneumonia. When you, my colleagues, are presented with lung CT of interstitial lung disease,
Mm-hmm.
exclude first the three common disease. After that, start to think about the finding. This cystic changes, which is scattered, okay, in this manner with lymph node. Yes, thank you, Dr. Zainab. Thank you.
Mm-hmm.
But there are one friend in the head seat. So we must, why in the exam they love to bring interstitial lung disease? Because it is combined cases, combined
Mm-hmm.
finding. You must tell the finding plus the cause, which there are some signs in the CT itself talking about it. If I
Mm-hmm.
told you uh, this is the sign, guiding sign. Which disease of the interstitial lung disease to which related this cystic changes, this thin wall regular cystic changes?
Mm-hmm.
What come in
Yeah.
in your mind?
Yeah,
Tell
I
me.
just read the comment. It's yeah. I think
Hmm.
yeah, one of the comments was about lymphocytic interstitial pneumonitis, which makes
Yeah, it is
sense
very
together
important.
with the.
Yeah.
I'm sorry.
With
I'm
what?
sorry.
Yeah. Continue. I'm
Yeah,
listening to you.
yeah, it makes sense because there is underlying esophageal dilatation, which is also um
N- See, no,
um
obvious. I think
I
no,
can't see it.
no,
It's not
no.
really
This
dilated.
is not
Yeah.
not so obvious. Okay.
Mm-hmm.
This is lymphocytic interstitial pneumonitis or
Mm-hmm.
interstitial. Okay. Why this cystic changes in this manner is very characteristic. Very
Yeah.
characteristic. What is the underlying cause? What is the or what are the most common diseases associated with lymphocytic interstitial pneumonia?
HIV and Sjogren syndrome.
Okay, so this patient is joking. If I told you the patient is 10 years old and presented to you, or 15 years old, presented to
Mm.
you with lymph CT containing lymphocytic interstitial, what is the underlying cause?
Yeah, HIV then.
Okay, thank you so much. So when
Mhm.
the patient is so young, there are no underlying connective tissue disease or Sjogren syndrome because Sjogren need a long time, many years to cause this interstitial disease. But
Yeah.
in case of immunosuppression like HIV is very common in children or very young people to cause lymphocytic interstitial pneumonitis.
Mm-hmm.
Um, Sjogren, when it is complicated by lymphocytic interstitial pneumonitis, it is very serious, by the way, in Sjogren
Mm-hmm.
patient. Thank you, doctor, so much. My
Okay,
colleague, by the way, really, you did very well. The case is very not easy. Uh,
thank you.
I want to ask you, what is this?
When viewing this on coronal images, I decided to call it an infective pneumonia or an infective patch of consolidation.
Yeah. What is this? What's it
Which one?
indicate? This
It
one.
indicates,
What does
yeah,
it indicate?
treatment,
Yeah.
antibiotic treatment,
Hmm?
and follow up in 6 to 8 weeks.
Yeah. What's your is this related to the interstitial lung disease or something else?
It can be a superimposed infection. My
Excellent.
primary concern
Excellent.
when I saw it was because
Yeah.
people with usual interstitial pneumonia have higher prediction to a higher predisposition to development of lung cancer. So I was suspecting it to be a mass lesion, but when viewing it on coronal images, it showed air bronchogram. So yeah.
What is the difference? How to differentiate between a mass lesion or consolidation? Both of them looks like opacification.
Mm-hmm. I think the
In your
effect they
opinion,
have on the surrounding architectural distortion and the surrounding vessels and bronchial tree. If we see there is continuity of the vessels and the bronchial tree along and around it, so it's not disrupting their course, it's not causing infiltration or obstruction. I would think of it more as a consolidation.
one word, please.
Mass
Give
effect.
me no. Look here. This is
Mm-hmm.
ill-defined. Look, ill-defined.
Yeah. Mm-hmm.
See, but plus it may contain some air bronchogram, but the mass completely sharp, well defined, with
Mm-hmm.
almost no any air bronchogram. Okay,
Mm-hmm.
this is
Yeah.
very important, very important. Okay, my
Yeah.
colleagues,
Yes. Thank you
thank you
very
so
much,
much.
Dr.
The answer is Sjogren disease, uh, and it was lymphocytic interstitial pneumonia. Okay, my colleague, very important, very important to remember these cystic changes. Okay, either immunocompromising like HIV or either Sjogren or interstitial lung disease. There are speculation. Not speculation is يعني not a sure sign to differentiate between mass and consolidation. Why? One friend mentioned speculation. If you look here, you will find speculation. See, there are speculation here. But either this ill-defined or well-defined. Either this contain a bronchogram or not. Thank you so much. Next candidate.
Assalamualaikum, sir.
Welcome. Salam. This is 30-year-old patient presented with dyspnea. Go on.
Okay. This is radiograph chest frontal projection in a skeletally mature patient, in which I can see both lung fields appear normal, cardiac size appears unremarkable. Bony thorax, I'm looking at the bones, they appear normal. Trachea central, I'm going through my review areas. Retrocardiac opacity, no retrocardiac opacity, diaphragmatic outline normal. There is slightly increased lucency seen in left hemithorax, and left hemithorax is slightly smaller in size than right. And also there is oligemia. So I will correlate with history.
Where,
If
where,
there is any history, left
where,
side,
where, where?
left lung, left lung.
Call you request control.
Yes, sir. So left lung is more lucent and has decreased lung
Where?
markings.
Show me. Show me where.
Um, I think whole left lung is more lucent than right, and there is no rotation, and also there is oligemia. So I will check if there
No,
is any
the
history of
projection.
childhood
See,
bronchiolitis.
see. How can you be sure this is oligemia?
Sir, vessels more on right side, less on left side. Left lung is more lucent.
How can you be sure?
I will advise, correlate with history, if any history of childhood infection, bronchiolitis, and advise CT chest of this patient for further evaluation of my findings.
From X-ray.
Yes, sir. I will advise
From
lateral view.
X-ray.
Also,
No.
lateral decubitus
If
can help.
no. See. If you compare the vasculature here with the
Yeah,
vasculature, okay,
yeah,
this
yeah.
white lines, vasculature, okay,
Yes,
this is very sure sign. If you compare it, but this is after zooming. If you compare the
yes,
vasculature here with the vasculature here, because the
yeah.
patient is tilted or non-centralized, so it looks like this hemispheric is smaller, looks like not similar to here, but this is not the same of the first case. Why? Look, if you compare this mediastinum shadow with this one, okay, this is looks like larger, okay, and denser.
Yeah.
But why this is projectional? And second point, it is
Okay.
good to mention all of this. And the exam, if the examiner told you don't worry, this is projectional, so you must shift to searching about another finding. Okay.
Okay. Okay. I am looking at the apices. They appear unremarkable. Okay. There is some left paratracheal opacification. There is
Hmm.
thickening of left paratracheal stripe.
Okay. Uh,
Uh,
okay. What else?
okay. Um, CP angles appear normal. Retrocardiac area appear normal. Um, can I know history of patient?
Histamine.
Yes, sir.
Chest
History
pain.
of chest pain. Okay. So any no opacity seen in any of lung fields. Um,
Yeah. What
so
else? What else?
uh,
You have seen the AP and you didn't find
yes, sir.
anything.
Yeah, I want to see lateral
What
view. Yes,
if?
sir.
Yes. One of the most important next step to ask about the other views. Okay, tell me.
Yeah. Mm. Sir, may I know age of patient?
I think it is 30.
13. Okay. Okay. So very young patient. Um, in lateral view, I can see that lung fields appear normal, cardiac size appear normal, vertebral bodies, heights, displaces, unremarkable. There is some opacification in retrosternal area. The same, the finding that I picked on chest radiograph. Um,
Don't worry about it.
no,
What else?
okay. Uh, lower vertebral body appears lucent that normally are seen thoracic levels. And sir, I cannot find any pathology on this radiograph.
When, okay, when you are given lateral chest radiograph, you
Yes, sir.
look here and this is normal. What else?
Yes.
There are very important review area.
Yeah. Vessels appear normal. Uh, Retrosternal lucency, precardiac area appear normal. Cardiac size appears unremarkable.
Mhm.
What else is it can be?
Look at the dorsal spine.
Dorsal spine appear normal to me, sir. Lucent lower vertebrae, they are not dense to suggest any uh, pathology, any uh, uh, sclerosis, or their lower thoracic lucency is preserved, upper are not clearly visualized, maybe projectional.
Okay. When you are going from up to down, there are
Yes, sir.
something should be seen here or sign
Yeah, yeah,
over the
lucent.
lower dorsal. Yeah, what do you think?
Yes, they are lucent as compared to upper thoracic vertebrae,
Lucent or
not that.
less lucent, please? Again,
Less
please.
lucent, I think. Less lucent.
What is the name? What is the name of this sign?
Uh, I call it lucency over the lower thoracic vertebral bodies. I don't remember the exact sign.
What does it mean? Okay.
It can be due to any paraspinal or spinal pathology, or
What is your next step?
posterior lung lobes if there is any consolidation which is causing opacification of lower posterior part, or paraspinal mass that can cause this increased density, or
Okay.
primary vertebral pathology, any sclerosis.
Okay. So what is your next step?
So I will advise CT chest of this patient for further evaluation, because I couldn't find anything on this, and patient is complaining of chest pain.
Okay. What do you want? This one. Go on.
Yeah. Okay, I'm scrolling. Sir, is this single image? It's not. Okay, scrolling. Okay.
This is scrolling.
Yeah. Okay, this is CT chest axial post contrast. I'm scrolling through the images. I will
Mm-hmm.
scroll to the last cut. Then I will start describing my findings. Okay, I will go to the main finding that I picked in left lower zone. In left lower lung, I can see there is an area of increased density with internal cystic spaces and air bronchograms. The images are a bit lagging.
So what do you think?
Yeah, in a young child, I want to see the soft tissue window to see if this patch of consolidation has separate arterial supply or bronchus relation with this
One
structure.
second. Go on.
Yes. Okay. So there is an arterial supply from aorta, thoracic aorta, which is supplying this structure, and the venous drainage.
Yeah, primarily, what
Arterial
is your
supply.
primary diagnosis?
Yeah,
Yes.
this is sequestration. I'm assessing, is this intralobar or extralobar? Arterial supply is from aorta, and venous drainage I'm looking.
Yes. Yes. So what's your diagnosis, doctor?
Yes, sir, it's pulmonary sequestration, and
What
likely,
is your next
uh,
step? Okay.
yeah, I
What
will
is your
refer this
next step?
patient to pediatric thoracic surgery for management,
What is
because
the
this can
management,
cause
do you
repeated
think?
chest infection. They will resect
Yes.
this.
So thank you so much. So it
So,
is uh, It is extra lobar. Why? If we have enough time, you will see that the venous drainage is systemic. Thank you so much. The most important is not the CT, is the X-ray. When you present it with completely normal chest X-ray, and even after comparing each side and everything is normal, ask for the lateral position. One of the most important is the loss of normal lower hyperlucency over the dorsal spine. Okay, it called the dark sign of lower dorsal spine, as I remember. Very important. It means that there are not posterior only, lower lobar posterior pathology or mediastinal pathology, whatever. So something lower and posterior. What happened here is that this tissue density absorb more and more of the X-ray, so the spine lost of its normal dark sign. Okay, my colleague. So losing of normal dark sign of the lower, I
That
think,
also.
because one doctor asked, I think it is loss of normal dark sign of the lower dorsal spine. Thank you so much. It was finally extra lobar sequestration. It must be resected because it is a source of repeated infection. Next candidate.
Yeah. Good evening, sir. Candidate 4 here.
Yes, welcome. Doctor,
Hmm. Okay.
this is a 25-year-old male patient complaining of uh, or he is presented to you in the E&E department
Okay.
after trauma. Go on, go on.
Okay. Provided with a frontal chest radiograph of an skeletally mature individual. I'm looking at the lungs. The lungs parenchyma is clear. I don't see any nodule or mass or consolidation within the lungs. Regarding mediastinum, the cardiac outline is normal. However, there is an added opacity noted in the left paravertebral location, which is extending from superior mediastinum to inferiorly, and it is however, I can see the descending aortic outline separate from this area, this lesion, this area. Uh, Focusing on this is also causing slight right side of the heart border is normal. So I am looking at this lesion, and in the upper segment, I can see some air lucencies also noted within it. Sir, history was
Trauma.
trauma. Okay. So there are some air lucency also noted in the superior mediastinum. Okay. Apart from that, the CP bilateral CP angles are clear. There is no pleural effusion. The bony cage. I'm looking at the bone cage. I don't see any clear rib fractures or external injury. The clavicles are normal.
So,
So,
so
so
what's
my
your
finding in
finding
this,
again?
yeah, yeah.
Well,
So,
show me.
for this, shall I request the control?
Yes, yes.
Yeah. Okay. So I see an added opacity is noted along the left paravertebral location. Okay.
What's
Uh,
your differential
so
diagnosis?
I'm thinking of any mediastinal injury, vascular injury with a mediastinal hematoma, as it is homogeneous and
Okay,
running obliquely. Yeah.
what is the cause of
So
uh, paramediastinal okay, posterior spinal
in the
paramediastinal
background,
lesion?
especially in the
Yeah.
background of trauma, I'm thinking of mediastinal hematoma. However, the classic apical cap, I'm not able to see any apical cap or any
Okay, what is the
left-sided
causes?
pleural
Okay,
effusion.
say
Causes,
what
yeah,
is the causes?
okay,
What are the
yeah,
causes?
causes for mediation. This is first of all is aortic
What else?
rupture and aortic syndromes. Also injury to
What
the
else?
venous structures, especially SVC and brachiocephalic vein. Then maybe sometime if there is esophageal rupture also can cause some fluid collection in the mediastinum. So
What else?
vascular injury, my main
I didn't listen well again.
Mhm. Yeah, vascular injury, especially aortic injury, aortic syndromes,
What
aortic
else?
injury.
What else?
Uh, aortic venous and
Look well at
sorry.
this.
Hmm.
Look well at this X-ray. You will find the cause.
Hmm. Okay.
You will find the cause.
Uh, uh, I think there is just beneath the arch of aorta, there is some air lucencies, crescent like thing. Uh, any other view is available, sir? I would like to.
What?
In any laterally or lateral view is available?
No, no lateral view.
Hmm,
Anyway,
okay.
what's your
Or,
next step?
So for further characterization of this, I will suggest for an urgent CT chest with contrast, especially CT autogram for further evaluation. Okay.
Okay, go on.
So yeah, thank you, sir. Okay, I
To
am scrolling.
save
Yeah,
the time,
yeah, yeah.
it's easy to. Okay,
Yes.
go on.
Yeah.
Go.
I will just the provided the CT scan, contrast in and study of the CT chest. Uh, this is the arterial phase, I presume. Yeah, it's arterial phase. I'm scrolling. Just take a moment to scroll through the whole stack of images and then start commenting. Okay. Yeah. So yeah. This is in the arterial phase and okay. So okay, coming back again. So I can notice that there is along the course the upper four vessel branches of the outer randimarcule. However, I see there is an outpouching of the okay. Oh, this I think there is an aberrant vessel is aberrant. There is a incidentally I found there is an incident aberrant left subclavian artery. Okay, and apart from that, I'm trying to see for any contrast extravasation. However, I could not get till now. There is some soft tissue density is noted adjacent to the aorta, descending aorta, thoracic aorta. Hmm. I'm also looking for any here. There is no evidence of pneumomediastinum in this soft tissue. I have in routine practice. I will look it in the lung windows. So in these images, I can only see the soft tissue adjacent to the aorta, descending thoracic aorta. I could not locate any extravasation
Doctor,
or any outpouching from the
doctor.
aorta.
One
Hmm.
second, one second. The ascending, the aorta totally looks like normal. Okay.
Hmm. Yes.
What else?
Hmm.
Look here.
Hmm.
1 second. Leave the mouse. Leave the mouse.
Yeah. Okay.
Leave the
I
mouse.
have left.
What happened? Scroll,
So,
please.
yeah.
Can you
Yes, sir.
scroll?
Yeah. Yes, sir. Yeah,
What happened?
this is provided with the sagittal same image I have provided in the sagittal views, and I can see there is a clear fracture involving the lower thoracic vertebrae, and it is a chance type fracture involving the anterior and posterior elements. Wait, it's jumping actually. I can see that a
So,
fracture line
so,
is yeah. So
so
this
what
is a
is the
chance
cause
type
of,
yeah
1 second,
yeah yeah
what is the cause
yeah.
of the peri and paravertebral hematoma? What is the cause?
Uh, yeah, so probably this is due to some uh, thoracic arteries, I mean branches of the thoracic artery, intercostal arteries, or which arise from posterior to anteriorly, or some and also this is an emergency condition as I can see that there is
What is the
a
name?
posterior.
What is the name of what is the name of this fracture?
Yeah, so this is chance fracture, which crossing with the fracture line crossing through anterior and the middle and
Why
the
this is
posterior
a
column.
chance fracture? Why this is a short
involving
situation?
involving involving the vertebrae and also the involving the fusti elements.
Yeah, how many columns?
Yeah, this involving three columns. In this case,
Okay,
involving
is this a
all three columns.
stable or
Yeah,
unstable fracture?
it is highly unstable because the posterior fragments are appear to be encroaching the spinal canal. So this is emergency condition, and or urgent neurosurgical review should be done for this. And also further, I will suggest for a contrast for MRI of the spine to see for the cord compromise to level of cord
Thank
compromise.
you, doctor,
Yeah,
so much.
for yeah, yeah,
See
yes,
my
yeah.
colleagues, leave the mouse, please. As per our January candidate feedback,
Mm,
uh, most of them told me, usually after each examination, I contact some selected candidate and ask them what about the exam, like this to update my knowledge and to give you as much as possible the correct pathway
mm,
and advice. I think all of them insisted that and confirmed that the exam, the difficult cases were about atypical cases. So my
mm,
advice for all of you, as I told you before, 60% are typical cases, or 70%.
mm,
But the important and the big barrier are the atypical cases. Okay,
mm,
one of them something like this. This is a fracture here. If you have a look here,
mm,
you can ask
mm,
at least here we didn't have backs, but at least I'm trying
mm,
to simulate as much as possible. If RCR examiner.
mm,
So if you
mm,
told you start very good, very well, there are left paraspinal and to little extent right, by the way, soft tissue density or whatever, enlarged paraspinal stripe, whatever. But the abnormality is paraspine. And there are no apical capping. There are no enlarged aortic knuckle. Sorry, aortic arch or
mm,
knuckle. Okay. So almost we are away, or either, not away, or either this is aortic injury or something else. You are in doubt, this aortic or not. So give me the other differential, doctor. It may be vascular injury like aortic injury, or
mm,
maybe something else. What is this something else? Spine injury, vertebral fracture. Doctor, can I
mm,
zoom? Because in the
mm,
exam, really, the image is very nice and it is allowed for you to
mm,
zoom. If you
mm,
told me like this, I will receive that you are in the correct pathway. Besides that, the fracture is here. This one, I think, maybe
mm,
D11. Okay, here,
mm,
D10, D11, like this. Then, after that, everything will be very easy. What happened here? You presented with this one. And unfortunately, you are talking again about the aorta. Why? Look, what happened here? Here, the aorta ascending and arch are normal. Okay, but okay, the descending is surrounded by hematoma. But when you come here, there are market fragmentation. Ask me for any other brains, you will find severe unstable fracture. Okay, and also
mm,
if you look here to the aorta, it is very smooth. Okay, the source of bleeding, if you look here, I think here there are extravasation from the arteries here or the vessels here. I
yes.
think it is very difficult, by the way. Anyway, the correct pathway for the case may be one or two pathology, but when the aorta is normal, and by the way, this is not the proper angio, I think, because see, the kidney is pride.
Mm,
It is maybe arterial,
mm,
okay?
yes.
Maybe arterial. Anyway, you didn't, at least you can tell the examiner, doctor, the hematoma, despite it surrounding the aorta, there are no obvious extravasation of contrast. In correlation for the severe lower dorsal fracture, it is almost this hematoma, almost due to dorsal spine fracture. Okay,
Mhm.
you must
Yes, sir.
show the examiner that you have a vision. Why? If we are
Mhm.
confused, doctor, there are fracture, but I have low, mild, moderate
Mhm.
suspicion of vascular injury. So the
Mhm.
clinician will be confused. Should I send this patient to vascular or should I send him to orthopedic? And this is the point. This is the point in
Mhm.
FRCR why they ranking any one of us on the hot seat from
Mhm.
don't know the diagnosis, then unsafe, then they give very nice description. Confused, scattered gun, scattered gun.
Yeah.
This is the exact description.
Yes.
What mean by scattered gun?
Mhm. Mhm.
This is a
Mhm.
confusing radiologist. Confusing. He is confused and he will confuse the clinician. Okay.
Mhm. Yeah.
Frankly, some of us has been demarcated because this point, and they the report was about like this, or because due to this point,
Mhm.
he is confusing or scattered can. So we
Mhm.
must be accurate, define, sharp, and has a definite diagnosis. Okay, thank you, doctor, so
Yes.
much. Next
Yeah.
candidate.
Thank you so much, sir. Thank you, sir.
Sorry, next candidate.
Good evening, sir.
Good evening. Doctor, you are candidate 5?
Yes,
Okay. 55-year-old patient has a 2-week history of dyspnea, cough, fever. Um, he developed confusion, agitation, and behavioral changes. 1 second. Um, this is a CT chest. Go on. One
sir.
second. 1 second. 1 second.
Okay.
1 second. You can use the sidebar or the arrow.
Okay. I am provided with the CT chest or CT chest post contrast images. I will scroll through the images, then I will comment on study my main findings. Then I am I can appreciate large, solid, soft tissue density masses in the mediastinum involving the pretracheal, paratracheal, and precarinal as well as regions. The main bulk is right paratracheal. This mass is causing compression over great vessels, and SVC is not separately visualized from this mass. And brachiocephalic vein is also compressed. Rest of the great vessels are also compressed. However, ascending and descending aorta is normally opacified with the contrast. There are multiple collateral channels seen along the anterolateral chest wall. Next, multiple collateral channels are also seen. There is a few collateral channels are also seen along the abdominal wall. I am looking for the heart quadrate lobe sign due to the reflux of the contrast into the liver, which is also visualized in the segment 4. And I would like to see the I would like to see the lung window to see the changes in the lung. So in conclusion, it's likely a neoplastic disease process, which can be a lymphoma or primary lung malignancy with metastasis, which is causing marked compression over the SVC and collateral formation. I will immediately inform the on-call physician, and I call the IR team for the SVC stenting to relieve the obstruction. And that's why patient present with the facial edema, plethora, and swelling. I would like to check the lung window for further comment.
Yes. Okay, go on.
On the
Yes,
lung
doctor.
window, marked centrilobular emphysis.
Yes. Hello? Hello?
I can appreciate marked areas of airspace
Again, please,
opacities with
because I lost your voice.
okay.
Again.
There are areas of airspace opacities and ground glass haze with areas of breakdown and cavity formation, which is involving the right upper lobe, and the disease is also extending into the lower lobe as well. Right lung volume is slightly reduced. Few bronchiectatic changes are also seen in the lungs. Tiny soft tissue density nodules seen in the left zone. So I think it's a primary lung malignancy. Keeping in view the pattern, it can be the bronchoalveolar carcinoma with significant mediastinal metastasis and causing SVC syndrome.
Okay, so what's your diagnosis?
Sir, basically it's a neoplastic etiology. Likely it's arising from the lung and with significant mediastinal metastasis.
Could you show me where is the bulk of the tumor, please?
Sir, this is involving the right lung, basically,
Where?
with the whole of the right lung. It's like crazy waving type of pattern, ground glass haze with septal thickening and areas.
You told me this is looks like lung malignancy. Where
Yes,
is the
there
exact
are two
mass?
possibility. It can be the previous disease process, maybe previous tuberculosis, and the
Doctor,
primary.
see, my question is very clear. Where means you must bring the slice and show the examiner. This is, and
Okay.
indicate by your mouth, this is the mass that I suspect. Like this. Show me.
Sir, it's a diffuse involving process. No definite mass is seen. It is involving the right upper as well as the lower lobe. Diffuse disease
Okay.
process, which is involving the whole of the right lung with volume loss.
What is your next step?
Next, I would advise biopsy of this lesion, mediastinal lymph node
What?
biopsy. And the first, I will inform the interventional radiology for the
So
SVC
one
study.
second, one second. So the question, from which location, which side, or which loop do you will you advise the interventional radiologist to do his biopsy? From where? Which
CT
lobe
guided
you are
biopsy
in?
from
Okay. I didn't ask
CT.
you how. From where? What is the best, in another words, where is the best location for the biopsy?
So from the lung or from the mediastinum, you're asking.
Where? Show me. Show me by the mouse, please.
Sir,
Where?
endobronchial biopsy found.
Doctor, I'm not asking about the means. I'm asking about location.
Sir, I think
Where, where is? Hmm.
biopsy should be taken from this mediastinal lymph node.
Yes, this is the correct answer. You are escaping from answer. I'm asking you to give me this one. This is the main bulk of the tumor. But however,
Yes.
before the biopsy, do you think you told me, you informed me that this is a diffuse malignant process? Do you think this is logic? All of this malignancy?
Sir, bronchoalveolar carcinoma can also present in this, but in bronchoalveolar carcinoma, this is unusual.
Okay. But do you think if this carcinoma, the ribs will be very good like this, chest wall no invasion, not acceptable.
Sir,
So
in bronchoalveolar
what is
carcinoma,
your
lymph nodes.
before biopsy in case like this or in lung biopsy and lung cancer? I mentioned it many times. What is the examination that should be done
PET CT
before
should be
lung?
performed.
Yeah, let's see why. See, you will be surprised now. See, look. The main bulk of
Yes.
tumor is this one. But look here,
Yes.
this is fibrosis. Or at least not the same uptake as here or here. Look down.
Yes.
Here, see, the main bulk of tumor is superior, more superior. Down, down here, see, all of this obesity not related to tumor at all. This fibrosis.
Yes.
Second, if you have a look here, down, especially here, look, this is a tumor itself. Tumor cause superior vena cava obstruction. Okay. And if you go down, you will see here the lymphangitis carcinomatosa. Here, see, nodular
Yes.
septal thickening in a pre-bronchoscopic and pre-lymphatic. But the most important is that one, market, market obliteration. This is mass. The question, the candidate before, I think, not the last one, before the last one, candidate three, I ask her or him about the difference between the mass and the consolidation. If you look here, very sharp outline, very well defined. No, no any air program inside. Even
Yes.
the tumor markedly compressing the main bronchi inside. Compare here this bronchi, main bronchi with this here, bronchi. This is very important. Okay, my colleague. Finally,
Okay.
it was bronchogenic carcinoma with lymphangitis carcinomatosa. Okay, my colleague. Thank you, doctor, so much.
Okay. Thank you.
Welcome. Leave the mouse, please. Last candidate. Hello?
Hello, candidate 6 here, sir.
Yes. Yes. Doctor, this patient complaining of chest pain. And he have underwent this chest CT scan. Ultrasound.
So I've been provided with the CT chest lung window of a patient who complained of pain. This is post-contrast image in which I can appreciate that there are multiple reticulonodular opacities involving bilateral lungs, and they are scattered within the lung parenchyma. Can I request control?
Yes, request to be.
Okay, request sent.
Okay.
Okay, it's lagging a bit. Sorry, sir. I think there's some issue at my end. I cannot scroll properly. Can you
Okay,
scroll
let
for
me
me?
scroll. Yeah, leave the mouse.
Okay, so I can see that these opacities do not have any zonal predilection, and almost entire lung is involved. There is no pleural effusion. Apart from that, uh, I do not see any obvious abnormality. There's no pneumothorax, and some of these opacities are confluencing into consolidative patches, like the one in the right middle lobe. And also, I can see one in the lower lobe as well, left lower lobe. So, based on these imaging appearances, I would be thinking of since the patient presented with I think chest pain, yes. So I would be, I would like to think of any infective etiology like viral pneumonias, which can present like this. I would like to correlate with the patient labs if there are any raised inflammatory markers. And apart from that, in my usual practice, I would like to see the soft tissue window as well to see for any other abnormalities which could be involving the mediastinum or the vessels. But based on these imaging appearances, other than infective, I would be thinking of eosinophilic pneumonitis and raised
Why? One sec. Why
because
isn't
these
it much?
seem to
What
be
is the
scattered.
craze?
These
Yeah.
seem to be scattered in the lung parenchyma, or most are in the peripheral location. And I do not see any internal cavitation. I did not see
Are
any
you
evidence
sure?
of.
See, this obesities has two criteria to help
Okay.
you. Two criteria, both of them will help you. Okay. And besides that, I
Okay.
want from you to have a look on this one. See, you can, to save time, you can. Which one do you want? Hmm. Have a look here.
Okay. So this is the CT axial slice soft tissue window post contrast through the pelvis, in which
Hello?
hello. Yes. So I can on the provided images, I can see that there are a couple of prominent lymph nodes. Apart from that, I did see some.
Yes.
Okay. So in the abdominal, yeah. So I saw a necrotic lymph node within the left inguinal region, and couple of enlarged lymph nodes in the right side as well as along the external iliac regions. And I also saw some, I think I saw some necrotic lymph nodes in the mediastinum as well. I would like to go through those uh, slices as well.
So what's your final diagnosis?
So, considering the necrotic lymph nodes and these fleeting opacities, some of which do show internal air bronchograms, uh, and these lymph nodes did not have any internal calcifications, or I would have put TB as first, although the lung findings do not go with that. These do appear to follow the peribronchovascular bundles, so I would be thinking of sarcoidosis next. And since I also saw the enlarged lymph nodes, I would like to correlate with serum AC levels. If they are raised, then this is likely sarcoidosis, and I would like to refer this case to the
Why sarcoidosis? One second. Why sarcoidosis?
because they were
Is
enlarged
this
lymph nodes.
are this obesities has a specific pattern, specific shape, and I show you the soft tissue window for a reason.
Okay,
Okay, for a
so
reason. See, one by one, one by one. What is the distribution of this nodules or obesities? Look.
these are in the mm, these are randomly distributed. Few of these are in
No,
the
no, 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 no,
peribroncho.
no, 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 no. Yeah, not randomly. Look here, extending from centrally to peripherally, around something here. Look,
Okay,
look.
yes.
See, coming
So
from the hilum, around the vessel. What is the name? See, around the vessels, around the vessel, around. Very characteristic, very unique. See, what is the name? Fissural, even fissural here, around the fissures. What is the name of this distribution?
so this is perilymphatic.
Okay, pre-lymphatic. Okay, pre-bronchosvacular, pre-lymphatic. Okay, what is the shape? What is the shape of this nodules?
Spiculated, most of these.
What?
Hello, spiculated reticulonodular type.
Oh, okay. Not reticular nodules. This is speculated, but beside its speculation, it is very unique speculation. very unique.
Um, I'm sorry, sir, I'm unable to
Very
recognize this.
okay. If I told you this looks like flame-like, okay?
Oh,
Flame-like,
yes. Okay.
correct? Which history do you want to ask about?
So I want to ask about any history of immunocompromise.
Yes, so what's your diagnosis?
So these are likely secondary to PCP. I would think pulmonary Kaposi sarcoma. Yeah.
Excellent. Excellent. Why? Kaposi
S-
sarcoma is associated with cutaneous nodules. See,
Yeah. Okay.
this cutaneous, besides this lymph nodes, Kaposi sarcoma has
Oh,
very characteristic nodular flame shape. The nodule itself is looks like flame shape, and it is
okay.
of pre-lymphatic, pre-bronchovascular. This case, my colleague is very ideal. See, it is pre-lymphatic. As all of you know that the pulmonary lobule is hexagonal in shape. If you look here, really you will discover that the lobe or the interlobar septum is surrounded completely by this flam-shaped nodule. And besides that, look at the center or hilar, pre-hilar, pre-bronchovascular. There are two types of the lymphatic infiltration, either central, so it is pre-bronchovascular, or peripheral. Peripheral is subpleural. Okay, so there are widespread pre-bronchovascular, pre-lymphatic, flam-shaped nodules, plus these lymph nodes, plus this skin nodules. So it is Kaposi sarcoma, pulmonary Kaposi sarcoma. Okay, my colleagues, thank you so much. Thank you, Dr. Ali. Let's meet next, I think, Wednesday in another session. Thank you for all our candidates. Goodbye.
Thank you, Doctor. Thank you.